Today I'm joined by Dr. Craig Klugman, Professor of Bioethics and Health Humanities at DePaul University. I had the pleasure of working with Craig for 2 years when I was at DePaul myself, and I really can't think of anyone I've learned more from in these two fields of ours. So I'm extremely happy to have him on the show today. Craig's been playing some key roles at the local, state, and now national levels throughout this pandemic. He's on the DePaul University COVID Response Task Force. He's also the chair of the Ethics Subcommittee for the Illinois Crisis Standards of Care Task Force, and he's a member of the National Biodefense Science Board, which sounds like it must fall under Space Force. Is that correct, Craig?
I think so. Steve Carell is our leader.
Excellent, excellent. So before we get into the pandemic and everything, I don't want to assume that our audience knows necessarily what a bioethicist does. So could you just define your role in general terms for starters? What do you do under normal circumstances, when there isn't a global pandemic raging?
Yeah, so bioethics is, as your students probably know, is an exploration of the moral issues in the life sciences. And you'll find people doing bioethics like myself teaching in a liberal arts university. You'll find people in hospitals. You'll find us working for the government, for think tanks, as well as mainly in medical schools. So what I do is I teach students and I do research on different topics. In my case, it's public health ethics, it's end-of-life issues, and digital medicine are where I spend a lot of my research time. And then we also work a little bit at the bedside, depending on what your position is. You may do more time at the bedside. I work with Northwestern Memorial Hospital and I help them deal with the moral issues that physicians encounter when they are taking care of patients and the tough choices that have to be made. So we're in a lot of different places.
So I want to get into that and all of those bedside questions you were talking about in a minute. But why don't we start with this Illinois task force? You've been wearing all these important hats lately. What's your role been with them exactly?
So in 2013, the National Academies of Medicine, as it's now known, put out a report and a toolkit. And what they suggested was that major jurisdictions, so large cities, states, come up with plans for what if there is a disaster, right? So what if a virus comes in to infect your community? What if there's an earthquake? What if there is a dirty bomb that explodes in the middle of a town? How do we respond? Where do we put our resources, right? So who gets taken care of first? Who gets whatever medication is available? Who is the first person, who gets the hospital beds that might be available? And so I was leading the bioethics subcommittee or the ethics subcommittee. And our role was to come up with like what the bases of these decisions would be. So we found things like respect for persons. We came up with transparency and communication, that we shouldn't be hiding things, that we should be letting everybody know. Accountability. Public health has police powers, and so they get to make a lot of decisions like forcing you to wear a mask in states other than Georgia. And we can—
Too soon, Craig, too soon.
And so you can, they actually have those abilities. You can have people quarantine and you can force that on people. And so you want to make sure that you're using these tools and the money that's put into this responsibly, and that every dollar is accounted for, so you can explain why you used it and how you used it and where the money went. And so we came up with those ideas, and we came up with strategies for allocation. Some of the things we thought about were we wanted to make sure all people were treated equally, irrespective of their documentation on immigration status, right? That it doesn't matter if you're documented or undocumented in the middle of an emergency, everybody needs help. We wanted to be sure that nobody was disadvantaged because they were poor, or they were a person of color, or they were LGBTQIA. And so this sort of value of all human life was something that we put in there and has come up several times. This was then taken, it was adopted by the state, and from there, our legal group sort of looked at, well, what laws needed to be changed to make this happen. We had the public health group look at how they would institute things. We had the hospital association decide how that would be working for them. And so all these groups who usually don't talk to each other came together, the firefighters, the police, and they used this as the basis for decision-making. When COVID hit the fan back in March, this tool that I actually created, that I wrote, was used by the individual hospitals for how they allocate resources, ventilators, ICU beds, drugs that sedate people so they could be on a ventilator and have a machine breathing for them. And the hospitals were all really appreciative that they had something on which to base these decisions.
That's
So it was a
excellent.
project I worked on for 5 years, and I led my group, and I was part of the core planning group for the state. And in a moment of irony, we actually had to cancel our last meeting 6 years after the project began, which would have been in April, because we had to deal with the pandemic.
Wow. I mean, I knew you'd been working on this for a long time, but I didn't realize you'd put 6 years into this. That's really amazing. So in bioethics, as you know, we often split those decisions you're talking about up into macro and micro allocation. Macro would be which hospitals get how many resources. Micro would be that person by person level. Who gets the last ventilator in the ICU? Who gets that last dose of remdesivir? Are you seeing hard decisions like that having to be made in Illinois?
So it depends on your area. So in Illinois, not so much. We had the large decisions, so we got our allocation of remdesivir from the federal government, and the state had an allocation plan for which hospitals got it based on their population. You know, the more people you had in your hospital system, the more you got. And then we also set up a system like not everybody needed it. So if you didn't need your allocation, you could then sort of give it to others or put it back into the pool. Within individual hospitals, that particular drug, because its efficacy is not known, it doesn't seem to work well in the very worst cases, or the people who are struggling at the end of their lives, killed by the disease. But it seems to help people a little bit earlier. So there's been some experimentation. So that's been happening on the individual hospital level for which one of our patients gets our allocation. There's a little bit of both going on here. I mean, the work that I did was definitely the macro level. And the micro level of what's happening in the hospitals has been more challenging. One of the things that we tried to do is all the bioethicists in Chicago came together, and we've had almost weekly meetings every Friday. Sort of what are our challenges? What are the things we're considering? So we were talking about DNR orders. If you know, with COVID, because it lives in the mucus and the sputum in the lungs, doing chest compressions really dislodges all that. And so it's risky for the healthcare worker who's doing those procedures. So some hospitals said, well, we're just not going to do them. If you're a COVID patient, you get no CPR. The risk is too high. And the healthcare providers are the limited resource. We can't replace them. So they said that. Other hospitals said, no, we can't do that. Our legal counsel said it would open us to liability. So it was like, how do we did some comparison of programs and things. We ran out of things like tubing, plastic tubing, the kind that would be used for a nasogastral tube, so that as well as for dialysis. And so we had to have allocation plans for that. I told you we ran out of sedation medications. We ran out of antibiotics. And so we've sort of been reacting as things come along. But there were things in the macro plan that were helpful for making these small hospital level decisions. And things like we prioritize first responders. So if you ran an ambulance, if you were an emergency room doctor or nurse, if you were a truck driver bringing needed personal protective equipment supplies, if you were an electrician making sure the electricity was up and you had been working and you are continuing to contribute to the effort, then you get to cut to the front of the line. You would get priority. But if we couldn't kind of get you back to the place where you could be helping out again, then you were stood in the line along with everybody else. So and it's an idea of reciprocity, that because they are sacrificing themselves, they're not sitting at home quarantining, which might be driving us crazy, but it does keep us safe. It keeps our neighbors safe. They can't do that because somebody's got to make sure the electricity is on. Somebody's got to make sure the store shelves are stocked. Somebody's got to treat the patients in the emergency department. And so we owed them as a society a debt for them doing that work. So that's why we would give them the front of the line. And those were decisions that are helpful when you're thinking about, well, we've got 3 ventilators. The other thing we tried to do was to ask if we could overcome those limitations, right? So my hospital might have 3 ventilators, your hospital might have none. And you're like, oh, okay, do we take a patient off the ventilator so this next one can get on the ventilator? Now, we are 2 different hospital systems. We are both in it for ourselves. We've never worked together before. And so I'm like, well, I got 3 ventilators. So we wanted to set up a way that before you had to decide who got your ventilator, who got taken off the ventilator so somebody else could get it, that you would call me and say, hey, could you spare 2 ventilators? So that we weren't necessarily making decisions on that micro level of the individual hospital or hospital system, but that we were making decisions on a regional basis. We also wanted so that, say, we had different plans for remdesivir or back in its day, hydrochloroquine. Do not take that, it's dangerous and it does nothing for the virus. Want to make sure that's there. But it was a discussion for a while. We didn't want it to be that if a patient was going into my hospital and we said, no, you don't qualify, you don't meet the requirements for getting the drug, and they could walk across the street to your hospital and you go, yes, you meet the qualifications. Like, that's problematic because that creates chaos. It means that we're not using the system efficiently. So we wanted to set it up that we were using similar guidelines to avoid that sort of thing happening. So wherever they went, they were being guided by the same thing.
Wow.
And this was sort of establishing the standard of care.
Yeah, that's exactly what I was going to say. It sounds like a standard of care issue at the end of the day. All right, well, we'll talk more about healthcare workers in a minute and what they've been going through, but let's just shift to some national topics now because your mention of I can't say that word.
Hydrochloroquine, hydroxychloroquine.
Reminded me that on the federal level, I have a feeling you're going to have some strong opinions there. I'm looking forward to hearing them. So let me go out on a big limb here and assume you think some things could have been handled better, especially in those crucial first few months. Give us your sense of the federal response from day one up till today.
Well, we kind of haven't had a federal response. You know, in previous pandemics, 1918, for example, there was a much stronger federal response. And the irony is that we didn't have much we could do in 1918, but there was a sense of, so there were some things we did, right? So we took convention centers in large cities and the Army Corps of Engineers came in and converted those into emergency ICU rooms, right? And here in Chicago, they created 3,000 extra beds. I know at the convention center in Atlanta, they did something similar. I don't know how many beds they had. They did it in New York City. Well, bizarrely enough, this is exactly what we did in 1918, right? So that was a good response. The states, the cities could request this. They would come in, they would bring the supplies, they would build these, they would coordinate with the locals. That was great. Where we've gone badly is things like contact tracing. So contact tracing has been done very, very locally. For us, it's actually on the city level. My university is doing its own contact tracing. So every university has their own. Every city does its own. Some counties are doing their own. So like Atlanta might be doing it, but so might Fulton County. And there's strange overlaps there. So that we haven't had a coordinated response is challenging for that. Because that means if somebody comes to Chicago and maybe they get infected and they go home to Atlanta, you have no way to contact the people they may have had gotten it from here in Chicago or anybody they talked in between because there's no jurisdiction because we're not coordinating the responses. Everything's being left to the local, state or local level. So that's been a challenge. Testing has been an unmitigated disaster. And just for a great example, University of Notre Dame, from the beginning said they were going to open, they were going to bring people in. And what they did was they sent a test to everybody who would be coming to campus, students, faculty, staff, 5 days before they had to go to campus. They had to mail in a sample. And they tested these and they found 99.7% of people did not have the virus. And the few that did, they said stay home. So most people in public health, I know when they hear that number go, there's no way that could possibly be true. We know the infection rate in the general population is higher than that. Within 10 days, I think today's now their second week. They're ending their second week. They now have over 300 cases on campus. And they have closed for 2 weeks. They think they'll be able to come back because, hey, 18 to 20-year-olds, they're away from mom and dad for the first time. You want to spend time with your friends. You want to have a party. Like, this is normal, right? And in any other year, this would be perfectly fine and acceptable. But this year, it can make people sick and die. And so we've seen this with UNC. Purdue's dealing with it now. You know, it's just the number of schools keep going and going and going. So the problem, was there a problem? Why did this test that Notre Dame used not work so well? Well, what we have is there's 170 tests out there, and not a single one has been FDA approved. They all have an emergency use approval, which just means they have to show that technologically and theoretically they work, but they don't have to show that they actually work. And so a lot of these tests are turning out have a very high false negative rate. That means people who are positive being told they are negative. And the crazy thing about this virus is before you have any symptoms, 48 hours before you have any symptoms, you are shedding virus, you are spreading it. So you feel perfectly fine, tomorrow you get sick, everybody you saw for the last 2 days could be infected. That's why this is kind of a perfect storm virus, and it's the nightmare things of public health. So the fact that we don't have a definitive test, other countries have not had this issue. They've been sharing their testing criteria with everybody else. They've shared tests. The WHO offered to give the United States those tests. We refused, we turned it down. There is the other problem we've had besides the inaccuracies and unreliability of testing are data collection. We've done a terrible job of data collection. So hospitals for a long time were supposed to send everything to the CDC, who collects all of our national health data. Except a few weeks ago, the federal government said, nope, we want it all to go to the Health and Human Services. So now the CDC was cut out of this, and it was brought to an office that doesn't normally deal with this kind of data. And what they discovered after 3 weeks of this is that they had no idea. They couldn't capture the data. They didn't have any way to process it. They couldn't find anybody who would do it for as inexpensively as the CDC would do it. And so as of yesterday, this is August 20th, they are now asking the CDC to take back that effort. And then the fourth problem has been our experts, people who have been dealing with, we have not dealt in the United States with a huge pandemic in 100 years. But SARS ripped through parts of Southeastern Asia. MERS went through the Middle East just 10 years ago. Ebola has been repeated in Africa. Other parts of the world in part have had a better response because they have more recent exposure to, no pun intended, to dealing with epidemic outbreaks. And we haven't learned, and we haven't listened to the lessons that have been brought to us.
So why haven't we learned? I mean, that's something I want to get at here. What lessons are you taking, not just about this administration, but also just about us as a country? Resource-wise, I think we're clearly in one of the best positions to fight something like this, and yet it hasn't worked out that way at all. What are you taking from that?
So I'm going to argue with you on the resource-wise. It's actually not the case. So we know that China underreported the number of cases they had back in December and January. We also know that most of our personal protective equipment, the N95 masks, those are the ones the healthcare providers use that completely seal, can't have a beard with it, completely seal around the face, don't allow any virus in. Like, it's the gold standard. Most surgical masks are produced in China. And what the Chinese were doing, they were producing but keeping it for themselves because they knew this problem was happening. The United States doesn't manufacture these, or we do so in very limited quantities. The biggest manufacturer of it is 3M, a US company, but they don't actually make many of them here. So we didn't do that. We could have used, there's an act that allows the president to convert industries into producing needed things. This has been used in wartime, where automobile factories were converted into airplane factories and things like that. We had some of this with ventilators. Turned out ventilators aren't a great way to treat COVID because they cause more damage to the lung than the virus alone. But we could have done this for converting. I mean, when we realized that cloth face coverings were effective in preventing spread to other people, suddenly we had all these companies transition from making clothes and sails for boats, and like overnight, within days, they were producing these face coverings very quickly, very effectively. So we can do that. I think the big difference between us and most of the rest of the world are the things that have made us very successful as a country and have also made it an abject failure how we responded to this virus, is we are a country of individuals. We are, to use the phrase of the philosopher Charles Taylor, we worship individualism. He calls it individualism. It's the worship of the individual. And we have this idea of, you know, America first, and we don't need anybody else because we can handle it on our own. What this means is that responsibility for not getting the virus and not transmitting the virus is you. And if you look at the metaphors, you are at fault if you get sick. It's a weakness, right? You're not a good soldier. And that means that we don't respond as a community. When we've asked people to wear masks, not to protect your, well, face coverings, not to protect yourself, although now the latest evidence is that they do a little bit, but to protect everybody else, people went, oh, no, 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 my freedom. You're not gonna step on me. But it was never about you. It was always about helping somebody else. I mean, in a way, the seatbelts are the same thing. Yes, the seatbelt will protect you, but you're really protecting the rest of the healthcare system from having to expend so many resources in taking care of people in car accidents, right? And so this mask was a very simple thing, asking people to do. And yet, because of our individualism and our worship of it, people refused. People didn't have it. For example, the Sturgis motorcycle rally. 300,000 people, nobody wearing masks, small town. And I just heard a report today, Friday, August 21st, that the first cases have now been found in the lower Midwest, all attributed to that one thing. And that we are actually never going to be able to know how many are attributed to that one gathering because we don't have federal contact tracing. So these simple things.
Let's go back to that mention of metaphor that you made there. I want to get into the topic of language with you for a minute. You and I both pay a lot of attention to words in our work, maybe sometimes too much attention, but I think you're absolutely right that terminology really matters in this pandemic. What I have in mind here is all that, you mentioned soldiers, but also all that hero and warrior language that started to pop up, especially early on in reference to healthcare workers. Any thoughts on those turns of phrase and the impact they have?
I mean, you know, New York City, I have a lot of colleagues in New York City. I grew up around New York City. My daughter lives in Brooklyn. So they, you know, very early started because that was the place where this really took off. It was the second place we saw it in the United States after Seattle, but it's really where we hit our worst until a few weeks ago. And there were people that was cheering at 7 a.m. and 7 p.m. when the staff changes were in the hospital. And they were cheering our heroes. I was walking my dog the other day and there's a nursing home and they all have these signs up, you know, heroes work here. Well, hero is the idea that you do something extraordinary, that is above and beyond what you would expect a normal human being to do or that a normal human being could do. And there's been a lot of pushback in the medical community about that term hero. Because as they say, we're just doing our jobs. This is what it means to be a healthcare worker. This is what it means to put other people before yourself. And, you know, they tried to turn it around to be, you know, just wear your mask to protect us so that we don't get inundated. But, you know, it's not inundation. It's part of the oath and it's part of the values of being a healthcare worker is that a profession by its nature is a group of people in a trade who put other people first. They're altruistic, and their goal isn't to make money or to get glory for themselves. It's about helping others. Mm-hmm. And in the United States, that concept is heroic because we have this idea that you should be egotistical and selfish and do things for yourself. And that's sort of the maximum thing. It's Ayn Rand's objectivism, which has been moved into a religion in some parts of the country. Wisconsin, just above me. And, but it's for the healthcare providers, they want people to realize they're not making a sacrifice. They're doing what they always do. They are ordinary healthcare workers and all healthcare workers do this. And so it was for their psyche, it was damaging because it also felt like it set them apart because a hero is somebody you admire. It's somebody that you look upon on a pedestal. And what they need is all of us to pitch in and help out, right? And so they're not separate from us. They are us. And think about, so many of them are not living at home. So here in Chicago downtown, there's obviously tourism going on. So a lot of the hotels, the city bought rooms and any healthcare worker could stay there so they didn't have to worry about potentially bringing the virus home. Right? And so you had these people separated for several months. You had People would go, if they did go home, they would, we don't have many garages, but in Chicago, but in the suburbs we do, they would change their clothes in the garage, throw it directly in the washing machine, put it on hot, shower immediately so that they could minimize the risk of bringing in. Whether that would make a difference, we don't know yet, but it made people feel better. And so by calling them a hero, it made them feel like they were also expected to sacrifice themselves, right? Because heroes sacrifice. And they're like, no, I am not dying because you don't want to wear a mask. Now, we know, hundreds, I think it's 700 healthcare workers have been infected with COVID directly from their job. We know that, and it's probably an undercount.
Yeah, I'm surprised it's that low, actually. And of course, there's always this catch-22 when you employ battle metaphors and soldier and warrior metaphors, right? I mean, it's classically, it's the classic American way to get mass mobilization onto any issue, the war on drugs, the war on terror, all of our actual wars, right? And like you're saying, because of individualism, it's one of the few ways that we have available to bring ourselves together. On the other hand, it opens up this possibility you brought up that it turns healthcare workers into acceptable collateral casualties, right?
Right, because in a war there's an acceptable loss.
Exactly. So it sounds like a lot of this for you boils down, and sorry if this is a naive question, because I don't work in public health to the extent that you do, but it sounds like the biggest hurdle for any public health campaign is just culture. How do you get people to change their habits, especially on a dime when you're talking about an emergency situation like this? Deeply ingrained everyday practices, that sounds impossible. Is there a way to do it?
Well, so one challenge again is our culture, right? So we are possibly the only, or definitely one of the few countries in the world that separates public health from medical care. Right? In most places, those are combined systems that work together. But we, in the early 1900s, there's a great book, Paul Starr, Transformation of Social Transformation of Medicine. He found that when medicine professionalized the United States, there were things that doctors wanted to do because they were found to be lucrative, and there were things that were not. And so when people think public health, they often think healthcare for the poor, because that was something medicine didn't want. Taking care of groups of people, working with the government, because those were all things that weren't going to make money for a profession. And so there was a deliberate choice to split these in the United States that other countries didn't do. But yet when that physician is deciding whether to put a patient on a ventilator, or whether to give this remdesivir to a patient, it is a public health choice, because for their patient to get it means there are many other people who won't. And we don't train doctors to think in that way. I think we should, but we don't. So I think that's one of the challenges here. Now, how do you convince people to buy into things? It's a real challenge. So if you read some of the stuff from 1918 flu, they talk about the challenge of getting people to wear masks, that it was incredibly difficult to do it. They didn't have remdesivir, they didn't have ventilators, they didn't have antibiotics, they didn't have antivirals, they had nothing to try. What seemed to work well for them were they called them outdoor hospitals. And so the hospitals, we didn't have big convention centers, so they would build these huge military tents. And they would open up the flaps and they would wheel all of the patients into the sunshine. And so they would spend all day in the sunshine, and at night they would bring them back in. And when you think about the spread of the virus, COVID, that we're dealing with today, the real danger is indoor settings, large groups of people. If you're outdoors, please still stay 6 feet apart. Please still wear a mask. But the risk is lower of transmission than when you're inside and it's concentrated and you can't get the air to move. And so what they sort of stumbled upon actually makes scientific sense, but they would not necessarily have understood it in those terms. I mean, the germ theory of disease was fairly recent and new at that point and wasn't commonly known.
Yeah.
So how do you convince people? So this is an area in public health we call behavior change, and it is extremely challenging. I remember growing up as a kid, my parents wouldn't wear a seatbelt. And they said, well, if we had a car crash, the seatbelt would prevent us from being able to get out of the car. And, we as kids didn't wear seatbelts. We survived. It's okay. We made it. But now it's like, you wouldn't even think about that. And there's penalties for it. And we teach students, you all learned when you did your your driver ed, you learned that you had to buckle up or you wouldn't pass the test, right? So it's become part of the culture. In the 1950s, you'd see advertisements of doctors smoking cigarettes, right? You know, I tell my patients to smoke brand X, and they were paid for this, right? And now it's like, you might find the doctor smoking outside, but the doctor's going to tell you not to. So a lot of this is culture change. You know, some of the funny things that have come out of this is there was been this whole emphasis on hand washing, right? You should wash your hands, 20 seconds. And the funny thing is, so this means people weren't washing their hands before? Like using a restroom. There's lots of diseases that have a higher fatality rate than COVID that can be spread that way, like cholera, right? So there's some interesting things like, why don't we do this? And I think it's a culture change, and it's slow, it's generational. There's been a lot of analogies, talking about metaphors with HIV and the AIDS epidemic with this, because in a way we didn't understand totally how it spread at first. People thought maybe a handshake or a kiss, and now we know that's crazy. It's actually a very hard virus to get. Because we don't exchange bodily fluids all that much. And when we do so, we do it safely. Please do it safely. But we're getting, you know, there's some fun memes about this, like, you know, the people wearing their masks below their nose. And the meme is, I now understand why there are so many unplanned pregnancies, because people clearly aren't using their condoms correctly, right? So there's been a lot of interest there. One of the big differences is that HIV was hitting populations that were stigmatized and ostracized, right? So you had the gay population, you had Haitians, you had sex workers, you had IV drug users. And so they were people sort of on the fringes of society anyway. And there was less of a desire to develop a vaccine or to put the whole country on lockdown for this sort of thing. Whereas now we have a highly virulent virus. It's very easy to get, but it affects everybody equally. In fact, you know, at first it was people who are older and people who have chronic health conditions. And now the biggest thing that we're finding, at least here in Chicago, is it's 10 to 29-year-olds. That is it's over 50% of new cases.
Wow. All right, so we've been talking mainly big systemic issues up to now, healthcare, government, and so on. Let me just shift gears with you a little bit. Let's talk about our day-to-day lives during all this.
Sure.
It seems like, in a weird way, there are ethical dimensions to the simplest things we do now. And maybe there always were there, but I think we're more aware of them. How you walk through a store, how you walk down the street now takes on all of these extra bioethical responsibilities. And it makes me feel like our field is more relevant than maybe it's ever been in a weird way. So I'm just curious how you're relating to that personally as a bioethicist who also has to go through everyday routines like all of us. What kind of ethical dilemmas are popping up for you day to day?
Yeah, so I live in a small studio apartment. This is actually the hallway. And I'm here 23 hours a day. I leave an hour a day to walk my dog.
Relatable.
So that is one thing that I've decided is I can help. Not being an MD, not being a nurse, I can help by not becoming a patient. So that's one thing I do. But yeah, like going to the grocery store has become an anxiety-prone decision for me. So do I go to the store? Do I do pickup, where somebody who works in the store is going to go around and get my groceries and then meet me with my car, load them in? Do I get home delivery, like Instacart? So somebody else who, for whatever they're getting per hour, it's not a ton of money, but that's enough money to make it worth for them to risk their health and maybe bring the virus home. So in a way, I'm like paying somebody else to take on my risk of getting it. That feels wrong to me. I was fortunate. I have some family who works in healthcare. They send me some N95 masks. So I put on my N95 before I go to the grocery store. I carry around my hand sanitizer and use it frequently. I go at certain times. I go a Tuesday, Wednesday, or Thursday at 1 o'clock, because that seems to be, you know, if you go to Google and you look up a store, it'll tell you what the busy hours are not. So that's kind of the least busy time. But yeah, before I would go to the market like almost every day. Oh, I just need this one or two things. It's on my way home. I pick it up. And now it's like, I only go every 3 weeks. Or sometimes I pick up milk every 2. But it is a very different decision. Walking down the street, as I said, I walk my dog every day. I wear a mask. I do not leave my apartment door without a mask. I don't get on the elevator without a mask. I don't go to the dog run in my building without a mask. So walking down the street with my dog, look, the chances of if I'm passing by somebody in those 2 seconds, I'm probably not going to get enough viral load that I can get it. But if they're not wearing a mask, I've done this, it's horrible, but I do this thing to my dog. I go, my dog's name is Bonsai. I go, look, Bonsai, it's a bad person. And like, I'm trying to say it loud enough that they might hear it, but I'm trying to like morally train my dog, if you can morally train a dog, to react to people who aren't thinking about others. Sidewalks in Chicago, it's an older city, so they're fairly narrow. So what I do is I walk on the curb. I walk on the curb, I walk on the street to get around in person, whether they're wearing a mask or not. Because
do you feel like your training at the end of the day is helping you in these moments to feel comfortable with decisions you're making, or just flooding your head with all of these neurotic calculations?
A bit of both. I am doing what I need to do to feel safe myself. I know more than most people, which is terrifying. And because I know all the different, I have to keep up. A lot of people I talk to now who are, freaking out and having terrible anxiety over things, they're like, I'm just shutting the news off. I'm just not engaging anymore. They're like, you should do that too. And I'm like, my work is keeping up with this. I keep a track every day of the positivity rate in Chicago so that I can let my university know, so I can help them make better decisions. So I don't have that choice. So I am doing the things that allow me to navigate the world and feel I am being safe. But this is why I'm 23 hours a day in my apartment, because being out there is terrifying in a lot of ways. Is that part of what I've brought on myself? Yes. And part of it is what I know about what this virus can do. And it's not just, getting sick for a few days, 10 days, and then being better. I mean, it's pretty horrible sickness for 10 days, unless you're one of the people who have the asymptomatic version, and then you get through it. But all these people, I mean, the death rate it's not crazy. It's still like, if we let this run wild, we would still have 20 million dead people in the United States. But, we're at 173,000 5 months into this. And when you think about, it's now the 3rd leading cause of death in the United States in 5 months. That's unreal. So we have to make the choices that make ourselves feel well as that we are doing our part to contribute to others, right? So that's why I do the work I do. This is why I wear a mask everywhere, because I don't want to be somebody who's going to need that ventilator, going to need to take that resource away from someone else.
Okay. So just one last question for you, Craig.
Sure.
And if you don't feel comfortable saying it, that's fine. But I'm curious what you're predicting for fall. What do you think fall is going to look like on campuses in our country, globally as well?
Sure.
Do you feel like playing Nostradamus with us for a second?
I absolutely will. If I had a crystal ball here, I would pull it out for dramatic effect. So my university was planning on in-person classes. We were planning on hybrid classes, part online, part in person. We were fully online. And we were doing this up until mid-July. And we had, oh my gosh, the things we were playing with, like I learned more about elevators than I ever thought I would. So we have UV lights in the elevators that will, in the ventilation system, that'll kill we have towers in the downtown area so that it'll kill the ventilation. We've increased the amount of outside air coming into buildings. We've put in like HEPA filters into our filtration system. We put little stickers on the floors to limit the number of people in the elevator, and so that everybody faces a corner so they're not breathing on each other. Elevators have been crazy, but we've also taken classrooms that normally would seat 35 or 40 people, and we're putting 10 in there. And we're spreading them out. And we had to decide, like, what if somebody refused to wear a mask and there's a mask mandate? Over and over and over. Now we are fortunate we're in the quarter system, so we actually don't start till September 9th. So we could see all the mistakes everybody else has made. But as I was watching our numbers tick up, and Chicago's a place that never got really bad, and has kind of kept it in check. We never overran our hospitals. But I've been watching the numbers go up consistently since mid-July. And we saw what was happening around the country. And we saw what was happening in the fraternity parties in other schools, in the summer camps, in the summer sessions for schools, and everywhere you could congregating large numbers of people in indoor settings, you were getting outbreaks. New Zealand, which didn't have a case for 102 days, suddenly has an outbreak. It's 8 people, 8. But it's an outbreak for them because they hadn't had any in 3 months. And they can't figure out where it came from. So we still don't understand everything about this virus. So when I saw those numbers changing, I'm on our health group in the COVID response task force. I sort of like started showing them stuff, started putting up the daily counts until they were convinced by the numbers, right? So to convince people to change the behavior, to link back, you need good solid data from reliable sources, which, as we talked about with the CDC and the numbers being moved around, can be challenging. You need to appeal to people on a narrative level. So this sounds odd. If you want to get a law passed in the legislature, you want to get a new policy, you can show all the data you want, and you need to show data, but you need a story. You need to hook them in. So did you have somebody who died or got sick of COVID, or now has one of these chronic lifetime diseases where they need a double lung transplant, or the latest stuff is heart damage, permanent heart damage they're not going to recover from, and in 10 years there might be a whole bunch of people needing heart transplants. The lung damage, the liver and kidney diseases because it's a clotting disorder, and brain changes. Apparently COVID makes changes to your brain that resemble dementia. Like, even if you have no symptoms, you're getting the brain changes from this, right? So you don't want to get this virus. You don't want to get near this virus. And so it was about convincing this. And the frustrating thing is, we know the data. We know we're seeing things. And there's such this individualism, and it's not like we can't close the country down, but you should make your choices for what you can do, but you better show up to work. You better show up to school. So I think my prediction is that pretty much every school that opens will close within 2 weeks and go online fully, which is really hard for faculty and staff because, you know, we've put months and all this effort into doing this, and then we have to pivot once again like we did in the spring on a dime. And we could have been spending all these months making really amazing online education like you're doing, Professor Eagle, making these videos and engaging people. So that's going to be a problem. We're also going to have the challenge that things are going to get worse. And it's not for any political decision, but things are going to get worse because we're getting into flu season. And the flu starts in October. The immunization is available now. I want to plead with you all to get your immunization because the symptoms of COVID and the symptoms of flu will look exactly the same. And so people who get the flu now are going to have to get COVID tests or short tests. We're short the nasal swabs. We're short the reagents you need to do this. There's some new emergency use spit tests that everybody hopes are going to be better. Again, emergency use, not full FDA approval, not fully proven. Universities that are doing frequent testing are basically using their own tests that they've developed in a way they're experimenting on their own students. And so, you know, we spun middle of August, the decision was made here that we were going to go, it's 98.3% online. We decided there's a couple of classes that couldn't be online. And so those are going to be allowed and very distributed. So we've got like ballrooms that are going to have 12 students in them, things like that. And I felt so much better like this weight relief. So I think when flu seasons start up, things are going to get more complicated. And it's going to be harder for us to make distinguishing, you know, people go to the ER every year for flu. A lot of people go to the flu every year. A lot of people die of the flu every year.
So it sounds like you think that hospitals are going to be passing capacity again and even states shutting back down completely?
No, I don't think there's political will to shut things down completely. I think we'll go back to, so when the numbers started to rise here, we shut down indoor bars. We closed down a little bit on indoor dining, a little bit. There's things we know, like it's the indoor spaces. So you live in a temperate climate. It probably doesn't feel that way in August, but it is a temperate climate. And you will be able to, you know, go to an outdoor bar in January. They have heat lamps and you can wear a sweater. Right. That's not an option in Chicago where it's going to be 10 degrees and snowing. So we will have a de facto shutdown because the things that can work aren't going to necessarily work here. But by you can continue those things. But yeah, I think there's going to have to be some rollbacks. Depending on how the election goes, there might be, so Joe Biden said if he happens to be the person who wins, he's going to have a national mask mandate, right? I think and I know this is a controversial thing in Georgia, like the masks have been very helpful. There is really strong evidence that they help not only other people protected from you, but protect you somewhat if you have a 3-layer cloth face covering. So I think it is going to get worse. The prediction now is like 300,000 deaths by November, and we're at 175 at the moment. So yeah, I think those challenges are going to come in, and it won't get better for a while. It won't get better until we have good testing, good contact tracing, people willing to put others before themselves, and a vaccine. And Dr. Fauci, he thinks there'll be a vaccine by the beginning of the new year. I'm not that, I mean, he knows way more about this than I ever could dream of knowing. But to me, there have been other coronaviruses. SARS is a coronavirus, right? This is the second novel coronavirus. The first one, some of the common colds are actually coronaviruses, right? We have never had a vaccine against a coronavirus, period. We never, in 40 years, got a vaccine for HIV. You know, even though the PrEP pills prevent infection, they're not a vaccine. So I'm not as optimistic. I'm generally not an optimistic person, but I'm not as optimistic in this case that they will have the magical vaccine that will suddenly solve all of our problems that I think politically and socially we're waiting on. I wouldn't count on that. I don't know that we're going to have some new antiviral drug that appears out of the blue. It can take 10 to 30 years to develop a new drug. 10 is kind of fast. Remdesivir was not FDA approved, had actually no known use. We had no idea. It seems to have some effect in some cases, but there's nothing else sitting there in the pipeline that's going to just pop up like this. So it really comes back to sort of the basic public health things that we used in the 1918 influenza pandemic of wash your hands, wear a mask, stay away from other people as much as possible. If you have a roommate situation, stay in your own room. If you share a room with somebody, I was thinking about when I was helping design dorms here, again, things I never thought I would be doing. It was like, we have single dorms is where we're ending up now. But I was thinking, like, do we put plastic shower curtains on a rod down the middle on a string so that, because at night, if you snore, that's all that viral rich fluids that you're like projecting out. I know it's a little graphic, but a really good sneeze can go almost 20 feet. So think about that. So maybe at least if there was a plastic shower curtain, like a couple of bucks, that would prevent the transfer to the person in the other bed, sleep head to foot. Like, use common sense, take care of each other. That's the best thing we have. But there's no technology today that we've developed in the last 100 years that seems to be doing anything. And the best things seem to be what we were doing 100 years ago. And so if somebody calls you, you get a phone call or you get the app, we're using an app here, that you are a contact of somebody who came down with it, which means you spent 15 minutes with them, less than 6 feet distance, even with a mask. Quarantine for 2 weeks, get a test. Some of the tests are taking 8 to 18 days to get back. So you're still going to end up quarantining for 2 weeks.
Wow.
It's really the only thing that we have to do is to look out for one another. And I really think it's going to take us thinking more communally and not thinking about this. This is not a war. We are not fighting a virus. The virus won. You can't battle a virus. It won, right? It's done. So what can we do to take care of one another? And I think that's what it's going to take. 1918 took about 2 years. That was sort of its natural projection. Virus epidemics don't last forever, even if nothing happens, eventually it runs through a population. But that idea that it'll run through and we'll be okay because this has these chronic illnesses, in a way it looks more like polio, where you have lifetime health deficits as a result of it. That's why we don't want to get this. And if we can close off that reservoir, I don't think the answer is shutting down again. The economic cost was huge, but we can make smarter choices. We can provide income and support to help those small businesses and to help people who are out of work. Like if we came together, and could take care of each other, there's things we could do that we still have a society and an economy left when we come out of it. But as Joe Biden said this week, whether you like him or not, what he said was, we're never going to get the economy back. We're never going to get back to our lives until we've dealt with this virus. And we can ignore it. We can wish it away all that we want. The virus doesn't care.
The virus doesn't care. All right, Craig. Well, I knew this was going to be intense, and I knew I could count on you to be brutally candid about this, but thank you for all that you've done so far up to now, and thank you for doing this and all the great pointers that you've kind of worked into this conversation along the way for everybody. Thanks for coming on.
Having me. Please stay safe and healthy.
You too.
Thanks.